Hello, everybody, dear listener. Before we start off with this podcast, we owe you a little bit of information about a point in the middle, which is about 16 minutes into the podcast, where we unfortunately experienced a lack of sound for just a couple of seconds. What you won't be hearing there, and what I will say now, is that Dr. Bargman explained that even though they start with incremental PD in their patients with a low dose, after 3 years, only about 50% will need a higher dose than the one they had in the beginning. That's the missing part. Everything else is easily understandable. I apologize for this unperfection, and I wish you a great listening to our podcast. And now,
We're taking this, 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 we're taking with a pinch of salt.
like the song says, we're taking this with a pinch of salt. That is, we're trying to ask sensible, clinically relevant questions to provide you, our dear audience, with sensible, clinically relevant answers. All of this viewed through the goggles of a common sense perspective. My name is Andres Cobonet, and you're listening to A Pinch of Salt, a new ERA podcast series. It is an honor and a privilege to have as our guest today Dr. Joanne Bargman, who is a well-known expert in the field of peritoneal dialysis. Joanna, welcome to A Pinch of Salt.
Thank you. Thanks for having me.
Okay, I have to say that one of the main reasons for this episode today is that the talk you had at the last ERA Congress in Milan, because for me, that was, and I'm not exaggerating, honestly, that was a life-altering event, because it was the type of talk that a nephrologist who is a clinician first is literally dying to hear at any educational event. So it was the type of talk in which an experienced clinician shares a lifetime of practical and real-life clinical experience, all the little and not so little tricks of the trade that end up being so important for the patient. So a masterclass, so to speak. The talk could easily be named Joanne Bargman, a masterclass in PD. So I highly recommend to our audience that you listen to that talk in its entirety. If you're searching for it, it was on Sunday morning on the ERA Congress in the PD session. But now we're here today to discuss the start of PD, not just for patients, but also for doctors as well. There seems to be two types of nephrologists as far as PD is concerned. One group that is very excited about it, and the other group that recognizes it exists. And I think a lot of us think that we need to get more nephrologists involved in PD. And one of the main barriers seems to be a lack of experience and subsequent apprehension about doing something that you're not sure you know how to do. So we'll be trying to figure out what is the best way to approach some of the basics of PD. So on to the first question. I would like to go to the time before the actual start of PD, which is the time when we educate patients with advanced CKD on the options of treatment after failure. And it's very important to do this, I would say, the right way, in a balanced way, so that people know the options, including PD. So how do you explain, or how would you explain the pluses and minuses of PD to your patients? And what, in your opinion, are the absolute contraindications for PD, if there are any?
Well, thanks for those questions. I'd say that in my institution about 20 years ago, all the nephrologists got together and decided philosophically that we should be a home first dialysis program. And, what that means is that we really should try to encourage people to do dialysis at home, be it either peritoneal dialysis or home hemodialysis. And only if they don't want to, or there's a reason why they cannot, then they would default, if you like, to in-center hemodialysis. And that philosophy has happily been adopted by all the nephrologists. And we have a pre-dialysis clinic with nurse educators, and they also have that kind of philosophy too. So we're all on board with the benefits of home first. So that informs what I say to patients, and it informs what the nurse educator says to patients. I'd like to point out for people who are thinking about this that it's not like patients necessarily, when you tell them about home dialysis, jump at the prospect. They may be scared, they may be worried, whatever. So it's a process. And, there's something in psychology called stages of change, where you sort of oppose something in the beginning, but then you think about it, you become less opposed, then maybe a little more disposed towards it, and so on. So our nurse educators are very aware of that and will sort of process a patient through these states of change and acceptance. So in my mind, when a nephrologist tells me none of my patients want to do home dialysis, they probably just ask, hey, do you want to do no home dialysis? The patient said no, and that's the end of the discussion. So I think that's the first point. So it has to be a process, I think. And also, I think there are people, it's like we have an expression, there's cat people and dog people. You probably have the same thing too. Some
Mhm.
people just love cats and hate dogs, and other people the opposite. And sometimes I think when you explain home dialysis to people, some people think it's a great idea, and other people are just repulsed by it. So there's the cat people and dog people barrier that you've got too. So, like I said, it's a process. We don't sort of, the first few visits to the pre-dialysis clinic, the nurse educators will talk about what the kidneys do and what happens when the kidneys gradually fail. I mean, a lot of patients don't even know what kidneys do. So it's important to start not just with dialysis, but with, what's wrong with your kidneys failing and what are the consequences of it. So that's part of their education program. They don't just dive into dialysis and transplant at the first visit. And I think that's a very wise choice. I also want to put in a plug for a pre-dialysis clinic because I would say that in my peritoneal dialysis program, that probably the vast majority of intake to my home peritoneal dialysis program is from people who graduate from the pre-dialysis clinic. And if tomorrow, if the pre-dialysis clinic were to close, I think I would see a big drop in my PD numbers. So I can't emphasize how crucial it is if you want to build a home program that you've got to have some sort of established education program for the patients.
And
I
how
hope that,
many? Yeah, that was a great line of thought, especially the type the idea of it's a process for sure. So in that vein, how many educational sessions do you have for a typical patient that's nearing the end of his? I mean, maybe it's different for different patients, but typically, what would you
yes,
say?
I guess it depends how much time we have with them because some people just show up in the casualty department and they've got end stage kidney disease and they've got to start dialysis really quickly and you don't have the luxury of a lot of time for education. But mostly it's patients who if their kidney failure risk index is significantly high, then they can be referred. But some of them end up staying for years in the pre-dialysis clinic, and some of them even die before they ever come to dialysis. So it's
Yes,
really variable, but the nurses usually like to have at least six sessions
at
in
least
the,
six.
yeah.
That's
It,
perfect. Yeah.
and like I said, it's a process. I kind of liken it to giving up smoking, where, someone may say, can you give up smoking? They go, no. And then they think about it, sort of like pre-contemplative, contemplative, and then the possibility that it can be done. And, again,
That is
those sort of,
very true. I found it very hard to quit smoking, and I really hate it when I tried it for the first time, and then I read somewhere on the internet, of course, unfortunately, that if you don't succeed the first time, you won't the second time, which I thought was so terrible. And of course, I succeeded in my sixth or seventh time,
right,
and that's the only way. That's probably the only way to succeed, or one of the ways to succeed, at least.
right.
Okay, so oftentimes I think people think about contraindications for PD as in finding a reason why a patient can't be on PD. Do you think there are many reasons why a patient cannot be on PD, or what these reasons would be?
Oh, there's a few, and I guess some are anatomical and some are more psychosocial. So the anatomical are pretty simple, and that would be someone who's got like a frozen abdomen. Let's say they've had not lots of surgery. That is not a contraindication. We have patients who have had like 4 or 5 previous abdominal surgeries. We've had patients who have ostomies or ileal conduits. They can still do peritoneal dialysis. We just make sure that their PD catheter is put in by a surgeon who does advanced laparoscopic techniques, so they can look around and, take down any adhesions or so
Mhm.
on from the previous surgery. So I'm answering what's not a contraindication, but if someone does have like a frozen abdomen from, let's say, previous surgical peritonitis, ruptured bowel or something like that, we tend to shy away from it. Polycystic kidney and liver disease is also in and of itself not a contraindication. There are people who have enlarged kidneys and there are people who have massive, massive kidneys.
Yep.
So if they're simply enlarged, we usually find that there's enough room for them to do peritoneal dialysis. They are, at least from the literature, at increased risk of hernias and leaks, but we still don't see it as a contraindication. However, if they've got massive, massive kidneys, the kind that the surgeon says that one of them has to be taken out to receive a kidney transplant because there's just no room, then that I'm a little discouraging about someone to consider going on to peritoneal dialysis with very, very big kidneys. And to my mind, that's about it in terms of the anatomical contraindications. Probably a greater one is the sort of psychosocial issues. And it really depends if the patient is cognitively or psychologically able to do it themselves. And if not, if they've got a helper who can do it for them. So that would be important. And until such time as we don't have this terrible business of delivering boxes of PD fluid to people, you've got to keep in mind that like a month's work of boxes of PD fluid takes up a significant amount of space. And if you have a patient who otherwise would be a good PD candidate, but they live like in one room in
Yeah.
what we call a rooming house, where there's multiple tenants and each person has one room and a shared bathroom, there's just no place to put the boxes of PD fluid. So that would be like a social contraindication to doing any kind of home-based dialysis. So I think that is basically it. We're very lucky in my province because we have a home visit program where, like in France, nurses will come in and assist patients with their peritoneal dialysis. And that puts a lot of people who otherwise socially or cognitively wouldn't have been able to carry it out. It enables them to have peritoneal dialysis. And that was actually our government agreed to this, not necessarily because they love PD so much, but we made a financial case for it, that it's actually less expensive for the government to have the patient at home on PD, even with a nurse visit every day, than it would be for them to come to an in-center hemodialysis unit. But that's when you've got a single payer and you can make this kind of financial case to them.
Yes, exactly. Exactly. So if we go on and we think about groups that are, let's say, ideal for PD, one group would possibly be the elderly frail patient, who really benefits from in-home dialysis, not needing to be transferred all the time, maybe as an assisted PD, if that program exists. But sometimes in these cases, it's difficult to insert the catheter if you only have the possibility to do it under general anesthesia. So that's sometimes a limiting factor. I wanted to ask you how it's like in your clinic. And then the second part of this question would be, because you demonstrated with your first elderly patient how you went incremental and how that really changed your life. Maybe if you just explain that part as well.
Okay. So I guess the issue about the anesthesia is really not such a big one. We have a very experienced anesthetist who assists our laparoscopic surgeon in the insertion of the PD catheters, and they can sort of titrate the amount of anesthesia needed. And it really hasn't been a big deal. I mean, over the decades, we've had maybe one or two patients who went into heart failure around the surgery and had to be hospitalized overnight. But all in all, it really wasn't a big deal. It's interesting with the home assist. Again, if you look at France, the older the patient is, the more likely they are to be put on home peritoneal dialysis. Whereas I know, like in other countries such as the United States, it's the opposite. The older the patient, the less likely they are to be put on PD. So sometimes having a helper is really crucial for this. And we have a lot of very elderly patients in our program who really thrive on it. And you're right, like the older you get, the happier to stay at home. And Toronto, we have terrible climate, and it's like there can be snowstorms in winter and really hot in the summer, and it's not pleasant for elderly people to have to be bundled up and shipped to a in-center unit three
Exactly.
times a week. So I think there's a lot to be said about the benefits of home-based dialysis, usually peritoneal dialysis for the elderly population, especially if you have some link to a helping program, some sort of helper program.
Yeah, that's almost a necessity usually then, yeah. And with the prescription, how would you tackle that for an elderly patient, for example?
Well, I'd advise people to look at the ISPD website, which is www.ispd.org. And there are standards and guidelines, and the newest guidelines for so-called adequacy of peritoneal dialysis came out a couple of years ago. And you've got to look at the goals of the elderly patient. They aren't necessarily the goals of keeping like a young patient in perfect fit health so that they can eventually get a kidney transplant. It's different for the older patient. And basically, our philosophy is you want to minimize the burden of dialysis along with keeping them feeling well. So, and having said that, that's why the patient that you're referring to, we started off with incremental peritoneal dialysis because the patient had a significant amount of residual kidney function. And if they do, you can get away with less than the sort of usual prescription. So we just try to make it as easy as possible for the patient. And we find that we are very successful with that. And it's not just the older patients too. We also start incrementally with our younger patients too. Again, they also come to us with significant residual kidney function because it's usually an elective start on PD, and we will start with an easy regimen. If they're, for example, choosing to be on a cycler, our typical starting dose is the number of hours overnight that works for the patient, typically 8 hours, 3 exchanges, 1.5 liters each exchange, and then dry during the day. That would be like our starting dose. And the majority of our patients, young or old, start off with that kind of an easy regimen. And it's interesting because a lot of these patients keep their residual kidney function. So when we reviewed this, we found that by 3 years, that only half of the patients needed in their peritoneal dialysis prescription.
Yeah, yeah,
Does that answer
that
your
was
question?
that was very interesting data that showed that you only needed to change it in about half of the patients. So it's a similar prescription for the younger and the older
Yes.
generation, I see. But for the elderly patients, I guess, I mean, the guiding light would be as long as they feel well, we feel fine about it. But for the
Yes.
younger patient, we're sometimes apprehensive. Are we leaving, are we not, cleaning their blood enough? Is there some long-term problem that we're not seeing? What's your experience with that? Is it
Uh,
okay to just guide your prescription based on the actual clinical feeling and just the basic labs? Is that fine?
Yes, that's a good encapsulation of it. There's two things that we look at. One is how is the patient feeling? And sometimes we see that we've started someone on an incremental regimen and they're doing terrific for the first couple of years. And then they notice that their appetite isn't as good as it used to be, or all the things that we use when we decide whether to start someone on dialysis still apply when they're on incremental dialysis. So you've got to be attuned to whether they're slowly becoming underdialyzed because of a fall off of residual kidney function. So that's like the clinical part. And then, of course, the biggest clue that they're losing kidney creatinine clearance is that their blood creatinine starts rising. So, if you see that, then you know that if you haven't changed the prescription, that their residual creatinine clearance is going down. And that may not be an issue if they're still feeling terrific, but if they're not feeling as well as they were feeling before, it could be a clue that it's time now to start increasing the dose. And just like again in the pre-dialysis patient, if you see that their phosphorus is starting to rise, if you see that their bicarbonate is starting to go down, these may be biochemical clues that it's time to ramp up the prescription of peritoneal dialysis. Having said that, The commonest way that we ramp up the prescription of PD is to go from a day dry to a day fill. Now, suddenly you're changing the exposure to dialysis from 8 out of 24 hours to 24 out of 24 hours when they carry fluid during the day. And it's my impression that it's not really that burdensome. Instead of coming off the cycler empty in the morning, you have a last fill that you put in, then you come off the cycler, you keep that fluid in all day and drain it out at night. So it's not burdensome
Yes.
to the patient to increase the prescription that way.
Yeah, that sounds perfect. So if we move on to, so we talked about how we put patients on PD. Now we have to talk about, in the second and last part, how we put doctors on PD. I don't mean the method itself, but how do we get more doctors involved in PD? I mean, most of us work in low volume centers where the numbers of PD patients are low, so it's very difficult to convince your boss to be there 100% of the time. And then on the other hand, you need continuity. Medicine is probably at its best when you see the patient, when the same doctor sees the same patient all the time, then you can notice all these subtle changes you're talking about.
Right.
So what's the best way to, enter into a low volume PD center? Is that just being there once a week? Is it just being there for an extended period of months and then rotating? What would you suggest would be the tactic when going to your boss about it?
You need a PD champion. And, for years I've taught at PD University where people who come from centers, just as you've described, come to the PD University. They learn all about it and they're really enthused about it. And I don't think they're pretending. I think they really are enthused about it. And they all say when they go back to their center, it's like they've hit a brick wall.
Yeah.
So you need buy-in, like I described in our division. You need buy-in to support the infrastructure because otherwise, I don't think it's possible. I think it's very difficult. And also, when these patients in low volume centers get admitted to hospital, it also becomes very difficult. Who's going to do the peritoneal dialysis exchanges while they're in the hospital with pneumonia or something? That can also be a logistical nightmare for many of these low volume centers. So you need infrastructure, and that's hard in a financial sense and also in a enthusiasm buy-in sense to promote in your center if you want to grow it. So it is hard to keep PD going when you've got 5 PD patients. But I'm telling you that the enthusiasm of the nephrologists when they learn more about PD, I think is real. And as you know, there have been surveys of nephrologists. If you had end-stage kidney disease and you couldn't get a transplant, which form of dialysis would you want? And the number one answer is home peritoneal dialysis. So I think people do see the benefits of it, but you need the infrastructure to support it.
Yeah, I guess in the end, you have to have what is, I guess, the most important quality a person can have in medicine, which is persistence, right? You just,
Yes,
the key thing to quit smoking or change anything is to
yes,
keep going at it.
yes.
All right, that's great. That's great. Thanks for those pointers. I feel that we have the same experience. So, the penultimate question is that you're an expert in this field. You've been doing medicine for some time. There are young doctors coming up. What would be the basic, if you can only offer one piece of advice, one sentence, something, one thought to a young nephrologist, what would that be?
I must say that I find looking after PD patients compared to looking after in-center hemodialysis patients, it's like night and day. And I found doing rounds on in-center hemodialysis patients not pleasant at all. But as I teach my home dialysis fellows, PD clinic is usually like, have you heard of well baby visits? Well
No,
baby visits
no.
is like when you're a pediatrician or a doctor and a couple brings a baby and the baby's fine and there's nothing to do except chit chat. And, that's what the visits with our PD patients are almost like these well baby visits. We end up talking about what did they do over the summer? What are their plans for Christmas or something like that? It's really a pleasure. And having done this for decades, I still look forward to coming to my PD clinic. The patients, people who choose to do home-based dialysis tend to be, self-sufficient, interesting patients. And for young nephrologists, it's fun to do home dialysis clinics. Also, the home hemodialysis clinics are the same too. They're fun. They're a lot more fun, I think, than doing rounds on in-center hemodialysis patients.
Oh, I think that was the best possible pitch for PD that I've ever heard. I still like doing this and it's fun. So that's great.
It is. You got to have
so
fun, right?
yeah, I like to. I mean, most people should like to have fun. I hope we're not so far that we don't like to have fun anymore.
Yes.
That would be sad. So, on to the last question, which is like the classical getting to know you question, which is which book, luxury item, and 2 songs would you take to a desert island, and why?
So the book that I would want to take is by Gabriel Garcia Marquez, called 100 Years of Solitude, which is probably the best book I've ever read. And I'm sure, having the luxury of time on the desert island, every time I would reread it, I'd probably find something new in that book. So that would be my desert island book. My desert island songs would be anything by Crosby, Stills, Nash and Young, including the song Carry On, or anything by Steely Dan. So I'd be really happy to have songs from any of those 2 groups to come with me. And my luxury item isn't so luxurious, but I would love to have a nice plump feather pillow instead of sleeping on a rock or something.
Yeah, that sounds reasonable. Yeah, I think Crosby, Stills, Nash and Young would go perfectly with Gabriel Garcia Marquez together. There's a lot of magic in both of them.
Yes.
Have you ever read Master and Margaret by Bulgakov?
No.
I think if you like Gabriel Garcia Marquez, that's a must read. He
Okay,
wrote
so
it for yeah, he
email
wrote
me
it for
the details.
he wrote it for the last 10 of years of his life during Stalinist Soviet Union, where he was not able to publish anymore. It's a very, very peculiar story. He was one of Stalin's favorite writers. And when people agitated for him to be executed, he said, "You cannot execute a talent like that. It's just something you cannot do." Even he said that.
Yes.
But he couldn't publish, and for the last 10 years of his life, he wrote this novel that he never thought would be published. And this novel is just like a comment on the Soviet Union, but in a very magical way. It's actually the devil comes to Moscow, and
Okay.
then things happen, and there's so much wisdom in that. It's just the wisdom of somebody who's seen it all, I guess, but still wants to live and still wants to have a good time.
Right.
So, okay. Well, thank you, Joanna, for joining us in A Pinch of Salt. Ladies and gentlemen, thank you for joining us and listening to this episode. Please check out our other episodes that are already available and stay tuned for new episodes, which will be released every second Thursday of the month. Goodbye.
Thank you for inviting me.